Now that we've been introduced to the topic, let's go ahead and dive into psychopharmacology in more detail. As we're going through these broad categories of drug, remember that one of the things I'm interested in is your capacity to recognize which neurotransmitters are affected and how they're affected in terms of the neurotransmitter cycle. So let's talk about antipsychotics first. There are two different types of antipsychotics. Let's talk about typical antipsychotics first. Typical antipsychotics were the first round of antipsychotics that were developed around the 1950s, and basically what we discovered is the connection between dopamine production and hallucinations in people who suffered from schizophrenia, that people with schizophrenia had overactive dopamine receptors. So we discovered how to block dopamine receptor sites, and that's what typical antipsychotics do. They just full stop block dopamine receptor sites very broadly. This tends to address the positive symptoms of schizophrenia. As a reminder, when I say positive and negative symptoms, I don't necessarily mean good or bad. I mean a presence of an extra behavior or an absence of a behavior. So symptoms like hallucinations and delusions are addressed by typical antipsychotics, but not so much the negative symptoms. Haloperidol is the common name of a typical antipsychotic. One of the problems with turning down your dopamine is, if you'll remember, one of the other things dopamine is responsible for is fine motor coordination. So people can often develop tics or a Parkinson's-like movement disorder or something known as tardive dyskinesia. I've actually attached a video as part of this week's materials that you can look at that demonstrates various folks with tardive dyskinesia. It's once again a slight facial tic that they can exhibit, or a puckering of their mouth, repetitive movements of their facial muscles. And this is permanent. Once somebody is over-prescribed antipsychotics, they can never get rid of that facial tic. So that's something that was a side effect of folks who started taking typical antipsychotics back in the 50s and 60s. Atypical antipsychotics are a more recent version of antipsychotics that we've developed. And this is a class of antipsychotics. One particular class blocks a particular dopamine pathway that is associated with hallucinations and delusions, and also blocks serotonin receptor sites. Other classes work to just impact how dopamine is released. So there's various types of atypical antipsychotics that have been developed. They're a little bit more targeted and a little bit more specified. So rather than blocking all dopamine receptor sites, it tends to hone in on very specific ones, or just kind of impact how dopamine is released again. This type of antipsychotic tends to address both positive and some negative symptoms instead of just the positive symptoms. Clozapine would be an example of an atypical antipsychotic. There are still some fairly significant side effects. Whenever you're fiddling with the neurotransmitters in your system, you're going to have some side effects. Those are kind of understood to be fairly common, but they aren't as harsh for atypical antipsychotics as they were for typical antipsychotics. They include things like weight gain, which is actually a very common side effect of taking any sort of psychopharmacological drug, the development of diabetes, and impact on immune system function. Often people must be carefully monitored when they're first starting atypical antipsychotics in order to test their blood sugars regularly and their immune system function regularly in order to determine that they're not in danger. All right, let's switch gears from antipsychotics to antidepressants. So this is a family of drugs used to treat mood disorders, once again, most often depression. Our first round of antidepressants that was developed was MAO inhibitors, also known as MAOIs. And MAOIs were developed to treat depression. One of the things that this particular drug does is it prevents enzymatic degradation. So that stage of the neurotransmitter cycle where the neurotransmitters are re-released back into the synapse and either get sucked back up through reuptake or get broken down through enzymatic degradation. This prevents that from happening. And if you'll imagine, what that does is it increases more neurotransmitters in the synapse floating around there, they're less likely to get dissolved. And if there's more of them floating around, then they're more likely to attach to receptor sites and generate an action potential. So the general understanding behind this is that someone with depression has underactive brain, and that this increases the likelihood of action potentials occurring, and it also increases the presence of various excitatory neurotransmitters in the system that are often found to be lacking in someone with depression. So for example, if you increase serotonin, you help address mood, appetite, and sleeping. Norepinephrine helps increase focus and concentration, and dopamine helps increase reward-seeking behavior. And as you're all familiar by now, people who suffer from depression can have trouble with focus, trouble with sleeping, trouble with mood, trouble with appetite, trouble with finding pleasure in things they used to enjoy. And by increasing the amount of these neurotransmitters in the system, it's thought to help with some of those particular issues. MAOIs tend to have fairly interesting and dangerous food interactions. You can't have any organ meat, so things like liver, when you're on MAOIs. You also can't drink wine or eat any cheese. It is literally deadly. Just kind of one of those things in terms of what it does to your body. And there are, of course, other physical side effects. These are fairly common, once again, for people who are taking medication like this. Weight gain is, once again, an incredibly common side effect of any of these psychological medications. You're messing with serotonin levels, which tends to fiddle with your gut and digestive system. Sometimes people can experience insomnia and headache, and many people report a decrease in their libido or sexual drive as a result of taking these particular range of drugs. And that is, once again, also a fairly common side effect that people report when they're messing with their neurotransmitter levels. Sometimes it can lead to a really big drop in their sex drive. Another class of drug that we use to treat depression and also ADHD are tricyclics. Tricyclics specifically block the reuptake of serotonin and norepinephrine. As a reminder, once again, norepinephrine is released during fight or flight. It's also associated with focus. So by blocking reuptake, once again, that stage of the neurotransmitter cycle where the neurotransmitters are sucked back up to be reused again, this makes it so that there's more serotonin and norepinephrine specifically floating around in the synapse. You can think of MAOIs as increasing all neurotransmitters in the synapse. This just increases serotonin and norepinephrine in the synapse. Doxepin would be an example of a tricyclic. The side effects include, once again, digestive issues. When you're messing with serotonin, you're going to mess with the digestive tract. A lot of serotonin is housed in our gut. You are also going to have weight gain as a fairly common side effect. Sometimes people can find the excess of norepinephrine to be problematic. If they're being treated for depression, it can make them feel jittery and unpleasant. This is the big kahuna of antidepressants. It's one of the most commonly prescribed medications today. It tells you what it does in its name. SSRIs are selective serotonin reuptake inhibitors. As you might gather, it selectively prevents reuptake of serotonin alone. Tricyclics prevented the reuptake of serotonin and norepinephrine. This just prevents the reuptake of serotonin. It's prescribed for a wide range of mood and anxiety disorders. So it's used to treat depression, anxiety disorders, obsessive compulsive disorder, and once again, it tends to target serotonin and increase the amount of it in the synapse by preventing its reuptake, which helps folks stabilize their mood. Prozac and Zoloft are both examples of SSRIs. I actually have some examples of ads from Zoloft so you can see different ways that it's prescribed or has been prescribed in the past. And once again, it includes a really great little animation of how SSRIs work, so you can see a little bit about that in play. Once again, you're messing with serotonin, so digestive issues are going to be one of the things that people experience. Some people, once again, have a decrease in their sexual drive. Some people can feel a little nervous on SSRIs. Lithium is a mood stabilizer for folks on who have bipolar challenges, who have problems with manic episodes. So we don't prescribe antidepressants to folks with bipolar because sometimes, for example, that extra norepinephrine in their system can really kind of work against them. And mania tends to have a different sort of root when it comes to what's going on there. Once again, an excess of norepinephrine tends to come along with manic episodes, and so that can sometimes be a problem. So what lithium does is it impacts the sodium ions in the neurons, which has been shown to stabilize mood and reduce mania. So this is a particular treatment for bipolar disorder that works by addressing the sodium ions. If you'll remember when we talked about the neurotransmitter cycle and action potentials, I talked about gates opening up and reducing, increasing the number of positive ions inside an axon as a result of the gates opening up. That's kind of what this is addressing, the ions within the neuron. Because this impacts sodium ions, people who are on lithium need to have strict monitoring of their diet, and there's a potential for toxic buildup, so they need regular blood draws in order to monitor their bodies to make sure that they are handling the drug well. Anticonvulsants, as I mentioned before, are also sometimes used to treat bipolar disorder as well. So the drugs that we would prescribe to someone with epilepsy can sometimes also help with mania, which is once again thought to be overactive activation of the brain, and it kind of prevents that overstimulation from occurring. When it comes to anti-anxiety medication, those are mostly dealing with tranquilizers, so benzodiazepines and barbiturates. They lead to a sedative effect. Unfortunately, they have to be very carefully used because it's very easy for people to become physically dependent on them in order to function normally. Lorazepam would be an example of an anti-anxiety medication. Beta blockers are also fairly commonly prescribed these days. They tend to block epinephrine, which is released during panic attacks or during a fight or flight response, and that tends to help with calming. So it helps to reduce blood pressure. There's some things to keep in mind when it comes to our current understanding of these sort of psychological medications. It is sometimes challenging for people to remain on the same drug or same dosage over a long period of time. So drug dosages must be monitored. Sometimes people have to switch their medication or their dosage. And so it's one of those things where it's not a magic pill that you take once and you're set. Sometimes that sustained medication can be a challenge and a struggle. This is also very important. Not all medications work for all people. There's a group of folks out there who have what's known as treatment-resistant depression, where antidepressants do nothing for them, and they're still in a deeply depressed state, which indicates that it's not just a matter of tweaking neurotransmitters as a way to treat something like depression. It can be more complicated than just increasing serotonin. Sometimes people can have challenges maintaining drug therapies. For example, one of my friends when I was growing up had OCD, and she found that sticking with her drug therapy, she didn't like how she felt on it. She felt less creative, she felt less artistic, and it was really challenging sometimes to get her to stay on her medication. She would go off of it all the time because she felt like she wasn't as good of an artist when she was on her medication. Of course, when she was off of her medication, rather, she wasn't as good of an artist because she was too busy doing ritualistic behaviors. But she couldn't really quite understand that sometimes when she was in the middle of an episode. So it was challenging for her. Sometimes when people are on antidepressants, they feel better and then they stop taking their drugs. It can be challenging to maintain drug therapies over long term, especially when it's making you feel normal. And once again, like my friend, sometimes people can feel as though they're losing touch with their self-identity or with their creativity. They don't like how they feel on the drugs, and it might not necessarily work very well for them. This is one of the reasons why it's important to not just have drugs as the sole option that people can have when it comes to treating psychological disorders. It's also very important to note that the side effects can be severe for some folks. They can really have distinct problems and challenges with a lot of weight gain or with such a drop in their libido that it has an impact on their ability to have a good relationship. This can be very problematic, and for some folks it ends up being a deal breaker where the side effects are too great. It's also important to keep in mind that the drug industry is for profit. They tend to want to hold on to patents of a drug in order to continue to make a profit from a drug they hold the patent to. You see this every now and then. Every 7 years, a drug comes up for a drug's patent comes up rather. And drug industry will often take a drug that's used to treat depression and then say, oh, we also treat OCD with it. Even though people have been prescribing it for OCD for years, the drug company will come up with this new treatment for it at the 7-year mark so they can hold on to their patent and prevent it from becoming a generic, which makes it more affordable. I talk a lot more about this in my health psychology class. I have a bully pulpit and I stand on it. So I've actually shown 2 different Zoloft commercials for you to take a look at. And one of them is when Zoloft was initially just used to prescribe for depression, and the other was when it was then used to also prescribe for social anxiety. And you can imagine that people prescribed it for social anxiety for years, but when it came up for a patent, the Zoloft company said, oh, guess what? We also treat social anxiety, and kept their patent for another 7 years. That's kind of the way that works. I'll also say, just in general, once again, we're learning how these things work all the time. We just learned, for example, that people who experience profound disorientation in ICUs, they used to be given antipsychotics for years and years and years. And we just found out, I think last year or maybe the year before, that giving patients in ICUs who are very disoriented and hallucinating antipsychotics actually doesn't help them at all. We're still learning a lot about how these different drugs work, how they interact with our system, and each time we develop a new treatment, it tends to be more targeted and better, but we still have a very long way to go.